Okay, hello and welcome to this first video in this series looking at ECG interpretation. And this first video is really going to be focused on how we can conceptualize the ECG and think about anatomically what the leads are looking at and what they represent within the heart itself. So, without further ado, a quick recap of normal conduction in the heart. As I'm sure you're aware, electrical conduction starts in the sinoatrial node, which is situated in the right atrium. That wavefront then travels across the right atrium, which depolarizes first, giving us the contribution to the first half of the P wave, shaded in blue here, and then travels along Bachmann's bundle into the left atrium, which depolarizes slightly later than the right, and thus contributes to the second half of the P wave, shaded here in green. This is important when thinking about the differences in P wave morphology in right versus left atrial hypertrophy. So in right atrial hypertrophy, you can imagine that blue section just getting a little bit larger, spreading out over the whole wave itself, making that P wave just on average a little bit bigger, a little bit distorted in shape. However, in left atrial hypertrophy, which we can normally see as a downstream consequence, or upstream, I should say, consequence of left ventricular hypertrophy, particularly in hypertensive states, what you get is a bifid P wave. That green contribution just coming slightly later now, as it takes a little bit longer for that left atrium to finish depolarizing, meaning you get the first peak from the right atrium, and then that second peak as that green left atrium continues to depolarize. So a large P wave, right atrial hypertrophy, bifid P wave, left atrial hypertrophy. Then we make our way down to the AV node, which is in health the only electrical conduction between the atria and the ventricles. Here you get slight pausing of the depolarizing wavefront, giving us the PR interval on the ECG, and then we travel down the left and right bundle branches, the left bundle splitting into the anterior and posterior fascicle. Right ventricle, the right bundle has no such privilege, and this travels down the septum, which itself depolarizes from left to right, and then the Purkinje fibers, which interpolate through that myocardium, a nice fast conducting wave of depolarization, ensuring that the ventricles empty from apex upwards to their outflow tracts. And that QRS, again, in health is normally nice and narrow because we're supposed to be traveling down specially conducting pathways which get things moving nice and quickly. So how do we measure this? Well, luckily, those electrical changes within the heart end up leaving or causing very similar electrical changes within the skin, and that travels throughout the body, so we can measure it by placing stickers on the body and measuring how that wave of depolarization travels between pairs of them, which we term leads. Okay, and all these leads are made up of two electrodes, either real or imaginary, more on that later. One of those is known as the reference electrode, and one of those is known as the searching electrode. You can imagine the searching electrode being the one that's looking towards the reference electrode, and it's looking for waves of depolarization that are traveling either towards or away from it. If it detects a wave of depolarization traveling towards it, you'll get a positive deflection on that lead in the ECG. And likewise, if it's traveling away from it, you'll get a negative deflection. Notice that these leads cannot see any electrical activity going on perpendicularly to their view. So let's place our stickers. Here is our first patient, first and only for the day. We have stickers on the right arm, left arm, and foot. These are the only three real stickers from which we can derive all 6 limb leads. So lead 1 is defined as having the searching electrode on that left hand, and the reference electrode on that right hand. So lead 1 is looking in a flat plane, looking at any electrical conduction moving from the right to the left. Lead 2 is looking from the right arm down to the feet. Lead 3 is looking from the left arm down to the feet. Remember, if there's any electrical depolarization moving in the direction along which these leads are looking, okay, then you will get a positive deflection. Those are the only three. Why do I say those are the only three real leads? Well, because the other ones, AVR, AVL, and AVF, come as averages. They don't have any stickers on. What we're looking at here, if I get AVR up on the screen here, we are looking at the average between those two stickers that are put on the left hand and the foot, so right in the middle, up towards the right arm. Now, it certainly doesn't stand for this, but you can remember it, if you like, as the average of the voltage moving towards the right arm. Likewise, AVL is the average towards the left arm, and AVF is the average towards the feet. Okay, so it all looks a little bit messy when it's on our person here, but remember, these are coming from real stickers. That's what we're measuring. We put those stickers onto the patient, and this is how we can construct the leads. We don't like to think about it like that, though, because we like to put it all on one neat circle. So let's move that over. 1, we can put nice and flat. 2, in that 60-degree position. 3, in 120 degrees. AVR up at minus 150. AVL symmetrical up there at minus 30. And AVF down at positive 90 degrees. Get rid of those lagging tails, and here we have the familiar cardiac axis diagram. So how do we determine axis? Well, first of all, what is axis? Axis just is just the descriptor that aims to describe, a descriptor that describes the average direction of voltage travel across or within the myocardium. Normally we're talking about the axis of the QRS complex. So what would the normal axis be? Well, if we think back to our electrophysiology that we revised at the beginning, most of that electrical conduction we would expect to be coming from the top right in that atrium down towards the bottom left. So again, on this circle, we are expecting it somewhere between that minus 30 and 90, and indeed that's how we define normal axis. So by looking at an ECG, how can we determine whether or not we've got a normal axis? Well, it's easy. We've got this diagram right here. The first lead we look at is lead 1. We want to know, is it positive in lead 1? Now, positive in lead 1 means on average, the electrical conduction is moving towards lead 1. And if it's positive, then we know that the axis has to be somewhere between, somewhere to the right of this, towards the right of this graph. So somewhere between minus 90 and 90 degrees. Okay, now that still doesn't tell us whether or not the axis is normal. Okay, because we could be more left skewed than minus 30. How will we know? Well, we need to look at another lead, which from this is the best lead to know that for sure we are not more negative than minus 30. Well, it's lead 2. The reason we look at lead 2 is because if we're positive in lead 2, we know that we are between minus 30 and positive 150 degrees, because otherwise we wouldn't be positive in lead 2. Now, if you need to pause the video and just have a little think about that, please do at this point. But let's shade in what positive in lead 2 means here. Well, there we have it in that light blue, overlapping with our positive in lead 1 to give us normal axis minus 30 and 90. So if you have an ECG and the QRS complex is positive in both lead 1 and lead 2, you know for sure you are normal axis. You don't need to be mucking around with any of this AVF business that I see some people using. Lead 1, lead 2. If you're positive in both, that's normal axis. You're not always going to be normal axis though. Let's say we're positive in lead 1, but now negative in lead 2. That means we are, so that light blue area is all that's negative in lead 2, but it's that beige area that overlaps with positive in lead 1, and that gives us our left axis deviation. Okay, so if we're positive in lead 1 and negative in lead 2, we know we are somewhere between minus 30 and minus 90 degrees, and that's a left axis deviation. Now, the most common cause of that you'll see on the ECG, if the QRS is nice and narrow otherwise, is just a left anterior fascicular block, which is quite common in older patients normally. When we look at the chest leads, we'll take a little closer look at exactly what that means. If, say, instead of being positive in lead 1, we are negative in lead 1, that means we're towards the left-hand side of this diagram. Okay, and then again, what we want to do now is, again, being positive or negative in lead 2 at this point won't give us any more information. What we need to look at now is AVF. Now's the time to look at AVF. And AVF can split that nicely into our right axis deviation, which is between 180 degrees and 90 degrees, and that extreme deviation. Okay, if you want to pause it here and just take have a little think about what we've done, please feel free. Mainly it's just looking at those arrows, drawing that perpendicular line on them and seeing whether or not what degree you're going to be between, what degrees you're going to be between if you're positive or negative in that lead. Okay, let's look at the chest leads. We need a different view to consider the chest leads. So now imagine we're looking at a CT or an MRI. We are looking from the feet upwards. That right ventricle is occupying most of that anterior space. That left ventricle, the thicker myocardial wall, is lying mainly posteriorly. We have these stickers on V1, a right-sided chest lead, V2, V3, V4, V5, V6 in the mid-axillary line. We don't really need to be concerned with the V2, V3, V4, V5 at this point, so we'll just look at V1 and V6 and consider how normal conduction appears on the chest leads. So if we look here, what is step 1? We'll ignore the atria for this part because we're just looking at QRS, which is just movement down the bundles. So the first thing we get, as I mentioned, is septal depolarization from the left to the right. Now, as we can see, this little wavefront is moving towards V1. So we get this positive deflection in V1. That's the R wave in V1. Likewise, it's away from V6, so we get a negative deflection in V6. That's our septal Q wave. So the same depolarization vector that gives us our Q wave in V6 is what is giving us our little, I didn't want to say pathetic, little R wave in V1. What happens next? Well, we get left ventricular depolarization. That happens before the right. Now, the left ventricle is nice and big, very thick muscle, and what that means is you get a very large depolarization vector. Again, it's away from V1 now and towards V6. Right? So that's our S wave in V1, and it's our R wave in V6. You can already see how the leads between this, V2, V3, V4, V5, will just be intermediate changes, and that's where we get that idea of R wave progression. The amplitude of the R wave should increase neatly as we go down the chest leads. What happens next? Well, we get right ventricular depolarization from the right bundle, slightly after, but it's all nice and narrow. It's all happening really quickly. Okay, so this is our normal QRS. But we'd be out of the job if everyone was always normal. So what happens in conduction defects? Right bundle branch block first. Now in the right bundle branch block, as you can see, I've annotated that neatly here, we get septal depolarization as normal from left to right. So no change so far. Small positive deflection in V1, small negative deflection in V6. We get that same large wave of depolarization away from V1 and towards V6 as that left ventricle depolarizes nice and strongly. So far, so normal. But what happens now? Well, the right bundle cannot depolarize the right ventricle because there's been no conduction down it. So you get this slow wavefront traveling through non-specialized, non-conducting, or not specialized for conducting anyway, tissue in the myometrium itself, moving from the left ventricle to the right ventricle. So that's positive deflection towards V1 and that negative deflection towards V6. And the whole thing widens because it's taking longer because those are not specialized conducting fibers. Now, you might already be seeing that slight M in V1 and that slight W in V6, that much hated William Marrow. And there it is. Nothing magical, spelt out there step by step. Let's look at the left bundle. So here, things change straight away. We have got right to left septal depolarization, giving us a small downward deflection in V1 and a small upward deflection in V6. This time we have that right ventricle depolarizing first towards V1, away from V6. Then just as we saw in right bundle branch block, this slow wave of depolarization traveling across the myometrium, spreading out, making that QRS nice and broad. I shouldn't say nice there. Making that QRS broad and spelling out our William. And there it is, William Marrow. Now, you might want to go over that bit. You can pause, rewind the video, just take some time to get used to that. Once you know what the limb leads are looking at, what the chest leads are looking at, interpretation down the line becomes much easier. So, to recap, we've looked at ECG sticker placement for both the real and virtual limb leads, ECG sticker placements for the chest leads, and how the QRS complex changes when compared to normal conduction versus left and right bundle branch block. And there you can see on the left the nicely derived cardiac axis diagram. Thank you for watching. Make sure to like and subscribe, and we will see you in the next video looking at more conceptual models for the ECG.